And with that, it's my pleasure to welcome to the stage former CEO of Kaiser Permanente Medical Group, professor at Stanford University, and author of Mistreated, Dr. Robert Pearl.
Thanks, Dan. Well, good morning. I want to thank Dan for those kind words. And I want to encourage any of you in the room who is engaged in social media to feel free to post things, tweet things, do whatever you'd like to do to tell the rest of the world, because the people in this room understand the challenges of healthcare and the opportunities are there. It's the people who are not in the room who need to understand. You know, I guess Strata's already reached 25% of all of healthcare. You and I both want to see 100%, maybe for slightly different reasons, but the opportunity to be able to use data analytics, the opportunity to be able to change how healthcare is delivered is a great possibility, and we can do it together, I believe. You want more information, you can always go to my homepage, robertpearlmd.com, and there you can also get information through my monthly musings, because I see this as an ongoing journey that together we have to make, as I say in the podcast that I run, American healthcare once again the best in the world. But let me start back at the beginning, and let me start with the story of my dad. And I always like to tell the story of my dad because it helped me to focus and start to understand the challenges of American healthcare and why so many patients are mistreated. My dad was a remarkable man. The son of two immigrant parents, he worked his way through college and then dental school. When World War II broke out, he could have stayed safely behind American lines, but instead he volunteered for the 101st Airborne. D-Day, he parachutes onto the beaches of Normandy. He's captured by the Germans, he and his fellow soldiers. He leads a daring escape through the darkened forests at night, brings everyone back safely. Tom Brokaw calls them the greatest generation. My dad was a tireless man, rarely slept more than 4 hours a night, until one day he found himself without energy. My brother is the chairman of anesthesia at Stanford, and he and I handpicked my dad's doctors, both the ones in New York where my dad lived for 6 months a year and the ones in Florida where he lived the other 6 months. Excellent physicians. They made the right diagnosis. He had a hemolytic anemia. His spleen was breaking down the red blood cells. He didn't have enough. He had an anemia, not enough red blood cells. They took out his spleen successfully. It looked like a great outcome. The doctors were excellent. They all understood that the spleen has another function besides breaking down red blood cells. It extracts out of the bloodstream a particular bacterium called the pneumococcus, a bacterium with a very hard shell. And when your spleen's out, you're susceptible to infection. And they all knew there was a very effective vaccine called the Pneumovax, we know it today. But the ones in New York figured the ones in Florida gave it to him, and the ones in Florida thought New York gave it to him, and primary care was sure specialty care, and specialty care thought primary care, and they never got it. Comes out to visit my brother and me in California. Has dinner at my house, goes to my brother's house in Palo Alto. 5 a.m., my brother wakes up, and there's my dad on the floor, unresponsive. My brother races him to the hospital, to Stanford Hospital. 4 days in the ICU, my dad's there, unconscious, 2 weeks in the hospital. He doesn't die during that admission. He's going to die as a consequence of one of the problems that developed during it. And of course, the diagnosis, pneumococcal septicemia. One of 200,000 people that year, and every year since, including this year, who will die prematurely from preventable medical error. The American healthcare system represents a 19th century cottage industry. It's fragmented. Doctors scattered across hospitals, across communities, hospitals scattered across communities. It's paid on a piecemeal basis. We call it fee-for-service. The more you do, the more you get paid. Whether it does any good at all doesn't matter. The technology we use is left over from the last century. In fact, a lot of it is left over from the century before that. And there's no formal leadership structure, capable of making the kinds of changes you'd expect in a 21st century business. The outcomes are what you would expect. We're the most expensive healthcare system in the world. We spend on the average, $11,000 per patient. The next highest, Switzerland, $8,000. Third, Germany, $6,000. Almost twice as much as every other nation spends on a per capita basis. We spend more on healthcare alone in the United States than the entire nation of India spends on everything. Its entire GDP for 1.2 billion people. We spend more than the nation of France spends on everything from truffles to champagne. We spend a lot of money, and what do we get? Amongst the 11 industrialized nations of the world, we are last. Last in life expectancy, last in childhood mortality, last in maternal mortality. We're the only nation in the world where mothers are more likely to die in childbirth now than a decade ago. We're the only nation in the industrialized world that people live shorter now than they did 3 years ago. And yet, I guarantee you, if we walk out of this room, go to the lobby of the hotel and ask people, how is the American healthcare system? They'll tell you it's the best in the world. There's not a shred of truth that we are the best in the world at healthcare. And it was this conflict between the objective information and the subjective perception that led me to research Mistreated. Why do we think we're the best when every piece of data says we're not? And the conclusion was that context, not information, shapes perception and changes behavior. Context. If you're going to try to make change in your organization, you can send out all the data and information you want. It's likely to not have much of an impact. Context shapes perception, changes behavior. Let me tell you what I mean. One of the things I looked at were old psychological studies. Why I had to look at old psychological studies? Because they could no longer get through a human experimentation committee. I teach at Stanford Graduate School of Business and Medical School, and there a lot of the research has come out of. Philip Zimbardo takes normal college students. He screens them to make sure they're psychologically stable. Half of them, he gives aviator sunglasses, khaki pants. They're going to be the jailers. The other half, you get OR greens, numbers, no names. He's going to bring you together in order to have you come up with a better way to run the jails and prisons of the United States. Within 48 hours, the jailers see the jailees as dangerous. They make the jailees clean toilet bowls with their bare hands. They put in as far as they can go in the rules that Zimbardo has set up, making sure that they are repressed. The jailees see the jailers sadistic. Board up the doors, keep them out. Within 6 days, the whole experiment ends. Now remember, everyone knows everyone else is just a college student. Put them in a fraternity party, they play beer pong all night. But in the context of a jail, the jailers see the jailees as dangerous, the jailees see the jailers as sadistic. Context, not knowledge, shapes perception, changes behavior. Another great example to me comes from Joshua Bell. Joshua Bell is the virtuoso violinist of the Boston Symphony. Saturday night, he puts on his tuxedo, takes his $2 million Stradivarius, goes to the concert hall and plays a 52-minute concerto. He makes $10,000. Monday morning, he goes to Washington, D.C., goes down to the Metro. Now he's in jeans, a baseball cap, still with his $2 million Stradivarius. Plays the same 52-minute concerto, makes $43. Context, not the acoustics, not the sounds, shape perception, change behavior. Or another great example from a colleague of mine at Stanford. He takes college students at Stanford. They've got to be 21 years old. And he invites them to participate in a wine evaluation process. He's going to do it, though, while they're in MRI brain scanners. What's going inside their brain when they're comparing these two wines? Now, I don't know how many of you have college student children or whatever. They know a lot about beer and not a lot about wine. So he's going to help them. He leaves the price tag on the bottles. This bottle has a $50 price tag, and this bottle has a $5 price tag. What they don't know, of course, is that the wine in both bottles is exactly the same. Now, students, what are they going to say? Of course, the $50 bottle of wine is better. They'll have all these reasons why, its aroma and its taste and everything else. We know that they're exactly the same wine. Doesn't surprise us because they don't know a lot about wine. But what's going on inside their brains? The reward center lights up vividly to the $50 bottle and not at all to the $5. Context. The price tag on the label shapes perception, changes behavior. Why do I tell you these stories? Because they're very applicable to healthcare today. We don't think about it that way. We think about healthcare as being a science. But maybe it's not quite as much of a science as we think. Now, what I'm about to tell you never happens in any of your hospitals. I know that, all right? But the rest of the hospitals in the United States. 1/3 of the time, when physicians go from one hospital room to the other, they don't wash their hands. The study's been done 80 times. 1 out of 3 times, they don't wash their hands. Now, every physician has to take a test as part of their credentialing process on hospital-acquired infection, the leading cause of death in hospitals today. They all score 100. They understand the most common bacterium is called C. difficile. It doesn't go through the air. It's only carried by people on their hands. They know that hand washing is effective, but the context of being late, of having an extra patient, changes perception. All of a sudden, they see themselves as sterile. I can't be possibly carrying a bacterium from hospital room to hospital room. Someone is doing it, but it can't be me. Another example in healthcare was President Bill Clinton. You may remember after he finished his 2 terms, his wife became the senator from New York before she became a candidate for president of the United States, and he developed chest pain. I don't know if any of you are from the city of New York, but the city of New York has one of the, I'll say the best data on cardiac outcomes. You can find it right now. It's a tremendous website, easy to navigate. All 15 hospitals in the greater metropolitan area, you can find second decimal point risk-adjusted data on the best to the worst, 1 to 15. Where does he go when he develops chest pain? The second worst hospital amongst all of the 15. And now he needs surgery. Where does he go? To the worst hospital for the surgery with the highest rate of complication. And what happens? He gets a complication. Context, the name, the marble, something else about the institution shapes perception. Here's second decimal risk-adjusted data, and he pays no attention to it, the man who helped lead healthcare reform before President Obama. The final example I want to give you is from a gentleman named Dr. Barry Marshall. Dr. Marshall is a pathologist. This is in the 1990s. He works in a hospital that does a lot of surgery for ulcer disease. At the time, peptic ulcer disease is felt to be caused by 2 factors. Number 1, it's caused by stress. And number 2, spicy food. The surgery at the time requires taking out about 3/4 of the stomach. And once that's done, besides the operation being dangerous with a lot of complications, the rest of your life you have problems with your digestive system. He looks at the specimens. There are these ulcers. And around the ulcer are bacteria. 90% of the time. He publishes this data, this association. 90%. We do things when it's 10 or 20%. 90% should be completely conclusive, and guess what happens? Nothing. No one pays any attention at all. So now he's going to do the greatest experiment in the history of medicine. First, he takes an endoscope and passes down his own mouth into his stomach and takes a picture. He has no ulcer. Now he walks to the pathology lab, gets a petri dish, and drinks it, an entire petri dish of bacteria. Goes back and re-scopes himself. There's the ulcer. Now he walks to the pharmacy, gets the antibiotics, takes them, goes back, scopes himself for the third time, and guess what? It's gone. Koch's postulates, the definitive proof of an infectious disease etiology, and guess what happens? Nothing. Context. When you pay $2,000 or $3,000 to do a gastrectomy, you can't possibly see an infectious etiology that requires a $20 or $30 visit for an antibiotic. Now, all this would be interesting, and it would tell us that we don't do a great job, and it would explain why we're mistreated. But that's also not why I wrote the book. I wrote the book because I asked myself the following question. If context can change perception and change behavior for the worst, why can't it do it for the best? What do we need to do? And I boiled it down to what I call 4 pillars. It's a roadmap for the future. How do we integrate care, pay it on a capitated basis, use modern technology, and provide leadership? And I'll go into each of these in a tiny bit more detail. But again, a lot of the information is in the book and at robertpearlmd.com. Integration. Why is integration important? Integration is important both horizontally within specialties and vertically between them. Horizontally within specialties because that allows you to be able to subspecialize, to get enough volume to do care. And a lot of the examples I'm going to use is from the time when I was the CEO in Kaiser Permanente, because those are the examples I know best. But there are many other organizations doing the same things. I asked the chiefs of OBGYN the following question. If you're going, and by the way, 80% or 90% were women. If you're going to have your uterus taken out, do you want to have it done with an open operation, one of the techniques, or laparoscopically? An open technique is a long incision. You spend 3 days in the hospital. For 6 weeks, you can't pick anything up heavier than a shoebox. Laparoscopically, you go home the same day, back playing tennis in a week. They all want to have it done laparoscopically. Okay, question number 2. If you're going to have the surgery done, how many operations would you demand that the surgeon did last year? Not who would you pick. But if the surgeon said, I only did X, would you say, under that circumstance, I won't have it done by you? And the answer is yeah, they all agreed. Somewhere between 3 to 4 a month, somewhere between 30 to 50 a year. What if I told you in the United States today, half of the hysterectomies being done are done by surgeons who do fewer than 10 a year? Half in the United States today. Once you are horizontally integrated, now you can subspecialize. Some people can focus more on the delivery area. Some people can focus more on the operative area. Some people can focus more on the office and the office procedures that are also difficult to do. Vertically, between specialties, primary care and specialty care, the process I put in place is called P-consult. It stood for phone consult. It's now become V-consult for video consult, or D for digital. When you're seeing a primary care physician, and the physician believes that he or she needs additional help. This is not some protocol, some review process, pre-authorization. This is the primary care physician saying, I'm seeing a patient right now, and I need to have added expertise. They would have sent the consult. Instead of that, we connect primary care and specialty care. Originally, as I say, through the phones, now increasingly through video. 40% of the time, the patient's problem is solved there and then. And 60% of the time, the process is moved forward because the testing can be done prior to seeing the specialist, so definitive care can be done. Dermatology is a great example. Primary care is a primary care physician who's seeing a patient with a rash and feels that he or she needs a dermatologic consult. Rather than sending him for a consult, we take a picture and send it to a dermatologist using modern technology. I don't know what it's like in your communities across the United States today. Getting a dermatology visit requires either 6 days, 6 weeks, or 6 months. 6 minutes. 70% of people have a definitive answer. They go to the pharmacy and their care is begun. Better quality, greater service, more convenience, lower cost. It's the power that exists when you're integrated. The second piece that's necessary is to move from fee-for-service to capitation. And I believe that that has to happen. Okay. Fee-for-service is simply volume. In June, I spoke to the CEOs of the 50 major companies in the United States. An audience like this, but obviously much smaller, 50 of them. And I asked them, how many of you have remodeled a kitchen or a bathroom or some part of your house over the past 5 years? Almost every hand went up in the room. And then I said, how many of you just said to the contractor, you do whatever you want and just bill me time and materials? Why are you laughing? Do you think that contractors are just unethical and doctors are all moral? Do you think that the issue is that they're just bad people ripping you off? No, context shapes perception, changes behavior. It's no different. But doctors won't admit that. We don't see it that way. 30% of what physicians do, according to the Mayo Clinic study, based on the New England Journal of Medicine's material, 30% of what we do adds no value at all. Adds no value. The most commonly done operation in orthopedics today is putting a scope in the knee and trimming up the cartilage. A series of studies done first out of Canada and now repeated in the United States have shown that 1 year later, PT alone is just as good as surgery plus PT. It's the most commonly done operation in the United States today. Context changes behavior, perception, and drives behavior. Another great example to me of the opportunity to do capitation. I live in Silicon Valley. And between San Jose and San Francisco, it's 50 miles, and there are 10 hospitals doing heart surgery. 3 of them, and by the way, this data is reported by the state of California, easily available on the websites. 3 of them do fewer than 300 cases a year. Now, cardiac surgical teams need to be available every day because sometimes they need to do emergent procedures. And when you have nurses available on call, you got to pay them. It means at least 65 days a year we're paying teams to be available with nothing to do. And on average, they're doing 1 case a day. How good could they be? How efficient could they be? How do you staff when you may have none, 1, or 3? How do you staff? How do you provide good care? When I asked my first-year MBA students, what would you do? Every one of them has an answer. Consolidate the 3 facilities into 1. But how many hospital administrators will close their cardiovascular service? Even if it's better quality at lower cost for patients. Context shapes perception and changes behavior. The third area of opportunity has to do with technology. And I'm a big believer that technology will be the future of healthcare. We're one of the few industries that have not figured out how to use the kind of data that Strata and others are providing to you and having that change the way healthcare is delivered. The opportunity to use that data requires that it be modern technology. In the first class I teach at the Stanford Graduate School of Business, I say to the students, what do you believe is the most common way that doctors send information, vital information, from one physician to the other? Now, of course, it's the first day of class. What do they know? So they look at me. I got to answer them. And I say, it's the fax machine. You know what they say? What's a fax machine? It's a technology from 1843, just to let you know how far back it goes. They can't imagine. People have to print the information off of their computer to put into the fax machine to go into the computer. How inefficient could you get? And that's American healthcare's technology today. I have the chance to speak to quite a number of technology, entrepreneurial conferences like this. And invariably, today we're not going to have time for question and answer, but invariably when there's question and answer, the microphone gets rushed. The first question is, Dr. Pearl, why do doctors hate technology? And I say, doctors love technology. What they hate is technology that makes their job harder. That's what they hate. And so much of the technology makes their job harder. And the reason is that we reverse the process that should be. What you should do is say, what's the problem to solve? And how can I use technology to solve it? Instead, they come up with an invention, a little Band-Aid that does EKG readings. And they say, oh, we got a device. We can send you 100 EKG readings on all your patients every day. Aren't you excited? What physician wants 100 EKG readings on their patients every day coming into their information technology system and making them having to review it and figure it out? It adds no value. It's absolutely reversed. But when technology is available, people embrace it. A great example to me is like a Fitbit. Anyone in the room have a Fitbit on or an equivalent kind of exercise device? Moderate number of hands go up. I don't. I have a Timex watch, just to be clear about that. Yeah, Dan's going to give me a Rolex when I leave, but right now it's a Timex. Anyway, so you're wearing that. I don't have one. So if I get this wrong, just let me know, okay? So as far as I know, that device you have does two things. It tells you how well you slept last night, and it tells you how far you walked around today. Now, those of you who are not wearing a device, do you not know how well you slept last night? And those wearing it, if you didn't sleep well last night, what's it going to do tonight to help you sleep better? Is it going to sing you lullabies? Now, I don't know what it's going to do for that, Dan and I are both marathon runners. He's run Boston a bunch of times. I've run 14 marathons. I carry my iPhone. It tells me exactly how far I went. If this is too heavy for you, you can buy a $5 plastic pedometer. It tells you how far you've gone. Unless you're training for the Olympics, it doesn't matter to the third decimal point how far the distance is going to be. So why is that device you're wearing the number one by a factor of 10 over any other device sold in the United States today? It doesn't change healthcare, by the way. There's not a single study showing that it does. But it solves a problem. And what's that problem that it solves? The December dilemma. Christmas or Hanukkah is coming. You need to give a present. It's got to look cool. They got to think about it all the time, wear it on their wrist, and it's got to cost between $150 and $200, and that solves your problem. You don't care if they ever use it to run or wear it or get healthier again. You've solved a problem. Those of you a little older may remember inline skates, 1998. Cost between $150 and $200. Half of the time, it never came out of the box after December 25th, but it solved the problem. So what technology solves the problems today? And what might solve it in the future? So one thing that solves it today is the electronic health record. I had the chance this morning to meet with some of the CFOs and technology leaders from this conference. And I made the point that we ask often the wrong question. We ask, is it cost effective? What's the ROI? From a purely economic way. But what we fail to understand is how powerful it is to improve health when information is available everywhere. A great example, again, coming from Kaiser Permanente. Across the United States today, 55 to 60% of patients with high blood pressure are controlled. We control 92% of the time. That's 40% lower strokes, 50% fewer heart attacks. We had the same doctors, the same medications, as the information available. So that if you're going to get your eyeglasses checked, they can note the fact you have hypertension and make sure you're taken care of today, not 3 months from now when you go back to see your primary care for another problem that sits out there. That information is powerful. It's also why we had 90+% screening of colon cancer. The colon cancer rate is declining in Kaiser Permanente, where every place else in the United States it's rising today, simply because we know who has not been tested. This is not colonoscopy, this is fit testing for about 80% of patients. The ability to do a test from the comfort of your bathroom at home, once a year for 5 minutes without a bowel prep, equally good without a family history or previous polyps. The opportunity to use that information technology system to now generate the material that Strata does and other people do around how do you coordinate that care to come up with new systems. That's going to be the future, and that leads to data analytics, the second very powerful technology. A great example is, as the CEO, I asked the following question. What what happens to patients who are in an inpatient med-surg unit, get worse tonight, get resuscitated, and end up in the ICU? What's going to be their mortality versus people with exactly the same problem who didn't have that decline tonight? And the answer is the mortality is 4 times higher, even though you get successfully resuscitated. And I said, can we predict who's likely in the hospitals today, because we have all the data, to see that decline so we can prevent it from happening in the first place? We looked at 1% of people. There's 3,000 patients. Right? So we're looking at 30 people amongst 20 hospitals, 1.5 patients per hospital. And for a human being, it would be impossible to analyze the data. But for a computer, it's straightforward and simple. It has all the information, electronic health record. It has all the laboratory data sitting in place. It has all the readings coming off of the monitors. It can look at that tremendous data set. And we're able to identify half of the patients and lower the mortality by 75%. And do the same thing now for patients being sent home from the ED who might come back, kids who might be having neonatal sepsis, and a variety of other problems. The next opportunity, and I think one of the biggest ones, is video. Video, I believe, is a technology that will dominate healthcare in the future. 30 to 40% of what we do in the office today could be done using video. I'm a reconstructive surgeon. I operate someone's foot. What do I tell them to do? Elevate it above your heart and come see me in 5 days. Did you ever try driving to the doctor's office with your leg above your heart? Walking up the steps? Yeah. These are crazy things that we can solve using video. We have, in Kaiser Permanente, we have stroke-trained neurologists looking at video screens of every patient walking into the ED and finding those people who have possible stroke and taking over the management of the patient at that minute. The key decision has to be made is, do we give thrombolytics? Give it to the right patient, you save their life, and you improve their brain function. Give it to the wrong person, and you kill them. The decision is hard to do. Typical hospital takes an hour, and over an hour, we got it down to 27 minutes. Higher survival, greater brain function using that technology that sits there. The final area that I want to mention is artificial intelligence. And that's the buzzword every place. And by the way, most of what we do, we call artificial intelligence, is not artificial intelligence. It's algorithmic medicine. It's good medicine, but it's driven by a human being. The area where artificial intelligence will be incredibly powerful is going to be in image recognition. The reason it's powerful is that you can take 5,000 pathology slides of cancer and 5,000 slides of non-cancer, and now apply the artificial intelligence technology to compare them. As humans, our brains can't do this. We use what's called heuristics, H-E-U-R-I-S-T-I-C. We learn a few things. If there's a lot of mitoses, the cells are irregular, if it seems to be invading, we call it cancer. By comparing 5,000 against 5,000, the artificial intelligence can come up with 200 different measures. And already in areas of pathology and radiology, it's outperforming physicians. It's going to be the same in areas of ophthalmology, dermatology. What's not going to happen, I don't believe, Dan and I had an interesting conversation about this, is the ability to actually do the more comprehensive medical evaluation. And the reason will not be because the machine couldn't do it, it's because the data we give it is so distorted. What physicians put in is not accurate. It solves their problem, it reminds them of things, but it's not as accurate as it could be. And if you put bad information into an artificial intelligence system, you get pure garbage out. So I don't think that that's going to happen. I think that will stay algorithmic, still applicable to data analytics, and the visuals will become the artificial intelligence. So what's going to happen if we don't change? And I believe what's going to happen will be disruption. In the business school, I've looked at over 100 industries. I can't find a single industry that was as inefficient and high cost as the American healthcare system that was not disrupted. Whether you want to look at computers, steel, automobiles, travel, you pick your industry. I dare you to find a single industry, outside of education, by the way, but a single industry that is as inefficient as healthcare and does not get disrupted. So where is disruption going to come from? Well, it could come from Haven. the union of Amazon, JP Morgan Chase, and Berkshire Hathaway. I know two of the three CEOs. They're very smart people. What they're most smart about is what they don't know. And they recognize they have a lot to learn. But anyone in this room who believes that Haven is only going to be a not-for-profit taking care of its 1 million employees, you probably also believe Amazon sells only books. Jeff Bezos is not looking at this as a not-profit venture for his 1 million people. He has 1/6 of retail. He wants 1/6 of healthcare. It could come from Haven. It also could come from these other large employers. The 50 of them, almost all of them are self-insured. You may have read in the New York Times about the company in Wisconsin that's offering its employees $5,000 to go to Mexico to have surgery done. They send along a Mayo Clinic-trained orthopedic surgeon. City of Santa Barbara today is offering its people $5,000 to go to San Diego for surgery because the one hospital in town is so high priced because it's the only hospital sitting there in town. Or it could come truly from offshore. Devi Shetty is a friend of mine. He's a heart surgeon trained in England and the United States. He runs 11 heart hospitals in India. He does heart surgery in India for $1,800 a case. If Devi were here and I said, Devi, what do you do? Devi would say, I set the price for a human life. I'd say, Devi, I'm a reconstructive surgeon. I fix kids with cleft lip and cleft palate. What do you mean? He says, well, every morning I come to the hospital, and there's 30 moms and 30 babies. They've all been well worked up. But in India, only 10% of people have insurance. I do a lot of free surgery, but I can't do it all for free. So I explain to the families that they'll have to borrow $1,800. The ones that can, I do their surgery. The ones who can't, bring the baby home to die. If I get the cost down to 1,200 more babies can have surgery, I will have elevated the price of a human life. His results, by the way, are better than almost any hospital in the United States today. His costs are lower. The day I visited him, his teams did 37 heart surgeries that day, including a heart transplant. That's more than most universities do in 2 weeks, actually most in a month, and that's why his results are so good. But I don't tell you this because I think all of a sudden your people in your communities are going to fly to India. But Devi's building, he's already started the process, he already has the first wings up, a 2,000-bed hospital on the island of the Grand Caymans. Anyone ever been to the Grand Cayman Islands? Yeah, beautiful, 7-mile white sand beaches, speak English, totally safe, tourist culture. Of those 2,000 beds, about 50 of them are for the Grand Cayman people. The other 1,950, Miami's a 1-hour plane flight away. He doesn't do it for $1,800, he does it for half the price. How long is it going to take the major businesses to say, I can get you better care, send your family on a vacation at lower cost, and what's that going to mean to the American healthcare system? Disruption could come. I told you that my dad didn't die at the beginning, but I tell you at the end how he did die. He was back in Florida, and he needed to have surgery on his feet for the ulcers that were created. During that time, he was in the ICU unconscious, lying in the hospital bed for 2 more weeks. And as part of by that time, he had developed atrial fibrillation and was on Coumadin. And he had to have the medication stopped to have the procedure done, and he was put on heparin, and somehow in the whole process, he ended up with a bleed in his brain. My brother and I got the phone call 4 o'clock Saturday afternoon. We hopped on the red eye that night. We arrived the next morning. There's my dad. He's strapped down in bed. He has a breathing tube in his mouth, a feeding tube in his nose. He's struggling against the restraints. A line of doctors out the door. The ENT physician wants to do the tracheostomy. The GI doctor wants to put in the feeding tube. The neurosurgeon wants to take out bone to let his brain swell. My brother and I look at the x-rays. My dad's not getting better. So we say to the doctors, thank you, but no thank you. My dad spends 2.5 more days in that hospital, and we never see another physician. There's no CPT code, no ICD-9 for compassion. In a fee-for-service world, you can't get paid. to be with a family in its time of greatest need. What I've learned in my research is not just how patients are mistreated, but physicians are mistreated by the current system that exists. So let me close my comments with one last story. Because as Dan said, I'm actually optimistic. I've told you a lot of negative stuff. And I tell you the negative stuff because that's the reality, and we have to accept reality. As long as we tell ourselves that the American healthcare system is the best in the world, change isn't going to happen. Until we face the reality of how expensive we are and how poor the quality is, the outcomes are, when measured against the rest of the industrialized world. Until we accept that, change won't occur. But I'm optimistic it can occur. And I'll tell you a story about a patient. This patient was born with deformity of all four extremities. He had no hand on one side, only 2 fingers on the other side, no foot on one side, and a club foot on the other. As a child, he had his club foot operated on. Today we do casting. He had a prosthesis put on the other side, and he grew up. He gets to high school, and like a lot of high school students, he wants to play a sport. What sport are you going to play when you have deformity of all 4 extremities? You can't play baseball or basketball or swim without a hand. He decides that he wants to play tennis. He figures he can get a racket and strap it to the side with no hand. He can throw the ball up with the side with 2 fingers. He's a pretty fast runner with his repaired foot and his prosthesis, and he makes the high school tennis team. He doesn't just make the high school tennis team, he actually wins almost all of his matches. Time's come to apply for college. He decides he wants to play Division I sports. Now, I don't know if any of you have played Division I sports, but it's almost impossible to play at that level without a scholarship. He applies to 100 schools, and he gets 100 rejections. Who's going to bring in someone with deformity of all 4 extremities? So he goes to Loyola Marymount in Southern California, and there he sees a sign for the tennis team tryouts. I mean, I want to think about the look on the coach's face when he sees this guy coming for tryouts without a hand and with a prosthesis on the foot. But it's open tryouts, and what's he going to do? Say, go home, I refuse to try you out? So what he does is he picks a player from the team and says, go to court 6 and play a set, and sure he can come back in 15 minutes, having lost 6-0. He beats the player from the Loyola Marymount tennis team. He makes the team. He's the only athlete in the history of Division I sports to play with deformity of all 4 extremities. He actually wins more matches than he loses in college. Now his time come to graduate. What's he going to do? How's he going to support his family? He says, I'm going to be a tennis pro. Not a Wimbledon pro, but a club pro, which is what he is today. My friend, who's his physician, said to him, how'd you have the audacity? How'd you have the audacity to believe you could make a high school team with your deformities? No less make a Division I college team, support your family. How did you have the audacity to do it? And he told my friend something I think about every single morning. I think you should think about going forward. He said, choice is more powerful than circumstance. Choice is more powerful than circumstance. I can stand here today and tell you all the reasons why healthcare can't change. I can give you justification for all the reasons why it is so expensive or why the quality is problematic. I can tell you why it's simply not going to happen, or I can make a choice, and you can make a choice to make it be different. And remember, choice is more powerful than circumstance. Today, American healthcare is not the best in the world. Patients are being mistreated. We can do better. And I know that you, along with Dan and Strata and the other people in this room, will do better. And I thank you in advance for all that you're going to accomplish. Thank you so much.